kindly ask that as we listen, please keep muted so that we do not interrupt the presenters.
Hello, we can't hear you.
Okay. We had a bit of technicalities that has been sorted. I welcome you all to today's session. We shall be discussing DVT and PA, and we're having a team of experts who shall be leading us in the discussion. I kindly ask that as we join into the session and as we listen in, please remember to keep your mics mute so that we do not interrupt the discussions. And we shall be allowing questions or comments intermittently as time allows. So keep your mics on mute. I'm going to go ahead and welcome the case presenters to introduce themselves. And later we'll also ask the experts to introduce themselves. My name is Jimmy Atyera. I'm a postgraduate student of emergency medicine, Makerere University, and I will be helping to moderate today's session. Let me go ahead and welcome Dr. Aggrey to introduce himself.
Thank you so much. My name is Dr. Aggrey Mulaavu. I'm an intern doctor at the Lira Hospital.
Thank you, Aggrey. Next, I'm going to welcome Dr. Nyakubaho.
Yes, thank you very much. My name is Dr. Ampuriire Nyakubaho. I'm an intern doctor from Kiruddu National Referral Hospital. and I'll be the case presenter for pulmonary embolism.
Thank you very much. Thank you. Next, I'm going to ask Dr. Linda to introduce herself.
Yeah, thank you, Jimmy. Good afternoon, everyone. I'm by the names of Linda Grace Nalugya, an emergency medicine physician with the Department of Emergency Medicine at Makerere University. You're all welcome for this session.
Thank you, Dr. Linda. We shall also be having Dr. Ddungu, who will be joining us online, and will be discussing with us the management, the causes, clinical assessment and diagnostic, and then emergency management, plus also the complications that could come along with DVT and PE. He will introduce himself when this time comes. In the chat, we shall be having Dr. Mary Ellen Lyon, who will be helping us answer the questions that will be posted in the Q&A, together with Dr. Kalanzi Joseph and Dr. Anand. They shall be helping answer those questions. So just in case you have any questions or comments that you want to make as the session goes on, you can feel free to post them in the chat, and you'll be sure to get them answered. With that, I'm going to go on and post the pre-test questions. We shall have 5 minutes to answer the pre-test questions, and then we shall after dive into the case presentation. So the test will be on your screen. Just answer them within that time. Thank you. As the pre-test comes, maybe we can go ahead and hear your expectations from this session.
No,
Your expectations. You can go ahead and raise your hand, and we shall allow you to air out your expectations for this session. What do you expect to get out of today's session, or what would you want the experts to talk about in regards to DVT and PE? I believe that all of us who are logged on with expectations. So could we just quickly hear those expectations so that we are able to intentionally plan to meet that, just in case there is any that maybe we had missed out. Someone comments that they're expecting to hear the nitty-gritties of management of the two conditions. Thank you. Someone wants to know about the risk factors. Any other? Someone wants to know about the follow-up of a patient who has been managed with either condition, either DVT or PE. Meanwhile, the pretest is up and running, so you can be answering the pretest questions. Someone wants to know about the advances in the management of PE. Then someone wants to know about the prevalences of upper limb DVTs and the common etiologies. I'm very certain that those will be well captured in today's session. Someone wants to know about why is the left lower limb mostly affected in DVT. Our experts shall be sure to answer those questions, to meet those expectations. Someone says they actually lost a student out of DVT, and I think this session comes in timely in helping us navigate and manage our patients who present with DVT, and also helping us to identify and manage this condition promptly so that we can reduce the mortality. Someone wants to know about the preventive measures for both DVT and PE. I'm very sure that that will be captured. Someone wants to know about the newest investigation, so investigative modalities in that could be used to assess patients that present with DVT and PE. Management in pediatric age group. Yeah, I'm very sure that the slides will be shared. Someone is asking whether the slides will be shared. And the recordings of the session as well will be shared. Okay, someone wants to know about DVT and COVID. All right, I think those are very good expectations that we have raised, and I'm very sure that our experts have captured them, and they will be able to they will be able to cover those expectations within this time that we have. So we are going to go on and welcome our very first case presenters. Today we're going to be having two case presentations and we shall be using those case presentations to stem our discussions. So I'm going to go on and welcome Dr. Aggrey, who shall be presenting to us the very first case of today. Over to you, Dr. Aggrey.
Right, thank you so much. Let me add the slides.
All right, we're going to go ahead and welcome Dr. Aggrey in the next 7 minutes to present the case.
Yeah, thank you so much. My name is Dr. Aggrey Mulaavu, intern doctor, Lira General Referral Hospital, and I'll be presenting the first case for DVT/PE. So this is the patient. It's that 5-year-old male and non-hypertensive who was on amlodipine and benzodiazepine, started with a 1-day history of difficulty breathing, started with chest pain, dry cough, and with his fatigability. However, there was no history of hemoptysis, no orthopnea, and no PND. Patient also reported a long-standing history of unilateral left lower limb swelling, which was associated with pain that worsened 3 days prior to admission, peripheral numbness, and inability to use the affected limb. He's a smoker with a 3-pack years and an occasional alcohol drinker. He has been unable to walk for about 2 months, and he has history of surgery. And as the echo sessions, we focus mostly on the emergency management of such a patient and how a patient is approached once received. So we use the ABCD, and in the airway and chest pain, we assessed it, and the patient was in obvious distress, but he was able to talk and support his neck, and the breathing respiratory rate was 32 cycles per minute. SpO2 was 85% on room air. The chest was symmetrical. There was equal expansion and bilateral entry. However, there was coarse crackles with unexpected wheeze in both lungs with the bilateral resonant percussion. So we put the patient on oxygen, and it was sitting at 98% on 10 liters by mask. Then the saturation, the patient had warm upper extremities, had the normal JVP. There was no pallor. Our BP was 140 out of 99. The pulse rate was 103 breaths per minute. Capillary fill time was less than 2 seconds. However, when we assessed the left lower limb, it was visibly swollen, hyperpigmented, and about 3 centimeters greater than the right. It was warm, tender, with absent peripheral pulses. So we had to put 2 IV large bore cannulas, took off blood sample for CBC, D-dimers, lipid profile, RBS, RFTs, electrolytes, and PTNR. Then in disability, the patient was alert with a GSS of 15 out of 15. People with conjunctive light, soft neck, normal power in both limbs, and with intact sensation. At that point, we also did RBS, which was 6.1 millimoles per liter. On exposure, we had to look at the chest, which was symmetrical, moving with respiration, no visible scars. The abdomen was normal fullness, soft, no palpable organs, and of course also looked at both limbs, and the left lower limb was already said it was visibly swollen and hyperpigmented and unequal in size with the right limb. So the patient was also in pain, so we had to give oromorphine 10 mils. We also had to give atorvastatin 40 milligrams, IV ceftriaxone, and also continue his antihypertensives. And when we looked at how the patient presented and on examination findings, the oral score was about 3, and we had to quickly do a D-dimer, which were markedly raised, about 1962 nanograms per milliliter, and we had to start on subcutaneous enoxaparin, as we also order for a chest X-ray, ECG, and the Doppler ultrasound scan of the left leg. The patient was being monitored, and we again assessed the airway after 15 minutes, and it was patent. We assessed the breathing. The pulse rate was 30. There was equal chest expansion and airway, and SpO2 was 96%, still on oxygen. The saturation, the BP was 140 out of 93, and the pulse rate was 96. The GSS was dropping kind. It was 12 out of 15 with eye opening 3, verbal 4, and motor 5. But the investigation is the CBC and all the blood sound, the bloody work up. We're still waiting. So in our sample criteria, the signs and symptoms in this patient. Patient had difficult breathing, had chest pain, dry cough, easy fatigability, had unilateral left lower limb swelling with pain, and it was hyperpigmented and peripheral limb numbness. Patient had no known allergies. The patient put that he had been using Moxil and paracetamol, and he had been applying local tabs on the affected limb. Local herbs on the affected limb. The past medical history was a non-hypertensive, and this was his second admission, and he reported that their first admission was due to bronchitis. The last meal was non-specific, and the event, patient rarely moves away from bed. The affected limb is a smoker, and he has a 3-pack years. He's an occasional drinker. So our problem list, based on the patient presentation and the examination, we were thinking that patient had a PE, ruling out pneumonia, a DVT, peripheral artery disease, acute coronary syndrome, and bronchitis. Investigation was still pending as the patient was still unstable, but we managed to do a CBC, which is on the next slide. So the CBC, the HB was 12.6, platelets 170, and the WBC was 9.6, together with the D-dimer, which I already talked about, and then as we're waiting for other investigations. However, as we're still waiting for the investigations, unfortunately, the patient began to deteriorate on oxygen, became unconscious, got a cardiac arrest. We checked the airway, sanctioned NSS questions. We attempted CPR. We gave 30 chest compressions at 100 per minute with 2 breaths using a bag mask valve, which were all unsuccessful, and lost the patient when we could not get any other more investigations. However, our diagnosis was mostly clinical, and we were using mostly the Wales criteria. Thank you so much.
All right, thank you, Dr. Aggrey, for that case presentation. We shall go ahead and welcome questions or comments towards the case that has been presented to us. Feel free to put up your hand and we shall allow you to ask your question. Anyone with a question? All right. Someone asked a question in the chat that what were the vitals at the point of deterioration? Dr. Aggrey?
Yeah, the vitals, the SpO2 was around 60%. Then we had to start the quick management. The BP was 130 out of 98. The pulse rate was 120. The GSS, the best was unconscious, with was around 8. Then for the HIV status, the patient returned, it was negative.
All right, thank you. Another question in the chat box is that did you think about lytic therapy, or what was lytic therapy given?
Unfortunately, no.
Well, I don't think we can hear you. You guys are on mute.
Oh, sorry about that. Thank you. Thank you, Aggrey. So no major general comment, but just to remind everyone who is listening in that this particular patient presentation is similar to what we see in our hospital settings. So as we go on, we are looking forward to interacting more and answering a number of particular concerns that might arise as we are managing our patients with a DVT. Thank you.
Thank you, Dr. Linda. Dr. Karanzi, do you have a comment about the case that has been presented?
Thank you, Dr. Jimmy, so far no comment, but I will give my comment as we go along. So far, in line.
All right, thank you. Thank you, Aggrey, for the case. We're going to go on and welcome Dr. Linda, who shall be discussing with us the assessment and investigation, then emergency management and complications of DVT. Over to you, Dr. Linda Grace.
Okay, thank you very much. You can go project the slides. Yes, welcome once again. So I'm going to be looking at the next session on how we are going to manage our patient that comes to the ED. So most of the time we see these patients either in the ED, but also at the back of your mind, think about that this presentation can be anywhere. For people who work in our pre-hospital setting, you could be called to pick someone from home, or you could be having a patient already on the ward and you're called to review, or it could be someone who has already been on the ward with you. So as the slides get projected, so for us to be able to appreciate in assessing this patient, we must first of all know what exactly we are looking for. So just a little background on what we're expecting. When we talk about DVT, we mean any abnormal blood clot forming within the venous system in the body. And this should be noted that it can happen anywhere in the body. Someone wanted to know which are the most common presentations. So commonly, as most of you that have managed these cases have seen, the lower limbs are majorly involved. However, we can also have the pelvis being involved. We can have the upper extremities being involved. So having a clear understanding of the possible areas where this can happen will help you know exactly what you're going to be looking for. So also about the underlying pathophysiology, we know about the virtuous triad. So here we are having a number of events interplaying together to predispose the patient to finally getting a clot. And in the virtuous triad, we are looking at any condition that will predispose you to getting endothelial injury or dysfunction. If we have any predisposition to stasis, anything blocking blood flow or obstructing blood flow will increase that complication. They're also having a hypercoagulable state. So in a patient who presents to you, most often times, these are straight on. You assess them and you're able to appreciate that the risk is there predisposing them to get this presentation. So when we are faced with this patient and we are assessing them, as I mentioned, either in the emergency departments as soon as they have come in, it could be an OPD presentation, or it could be a patient you're reviewing in the ward. So in our history, already from the presentation, they will tell you I'm having limb swelling. It could be painful, it might not be painful. However, also important to note that a patient can have the DVT and they do not have any symptom at all. So you see it as a coincidental finding as you're examining the patient, you happen to see that, oh, your limb looks more swollen as compared to the other. So keep that at the back of your mind as you're interacting with the patients. And then for those that will have the symptoms, they might tell you that they have a sensation of either red heaviness, the limb feels heavy, or they might note that there's been some color change in the limb. For those particular cases that are now becoming severe or complicated, they'll have these particular changes, profound. And so as you're interacting with this patient in your history, you want to exhaust the possible risk factors in this patient, as we are going to see in our next slide. So in these risk factor predispositions, still, as I mentioned earlier on, there is an interplay in all these conditions. So for the patient before you, ask about any prior history of being immobilized. This immobilization could either be because someone had a very long journey, over 4 hours, and they were seated, they never got up to stretch their legs, especially people who travel on buses, people who travel in flights. immobility can also happen in patients that are generally ill. They are very sick, they are bedbound, and they rely on someone to keep turning them. Then we see patients that have had surgery. Please mute yourselves, thank you. We see patients that have had surgery, either they have had major surgery to that limb, or as a complication of surgery, they have a predisposition for getting this DVT. And also, further still, we see that if there is any form of trauma, it will predispose the patient. If you're obese, the risk factor is high. If there is any prior history to having a DVT, you have another chance, about 25% of getting a DVT again. For people who either have known malignancies or not yet diagnosed, they also have a risk of this presentation. For females that are using oral contraceptives, pregnancy states, people who have had a history of a stroke. In our hospitals where we have particular procedures done, and this is common in our very critically ill patients where we have central venous catheter insertions. So these patients at an increased risk of getting DVT. So after I've exhausted our history taking, then next is going to be our examination. So depending on the setting where you are and the patient presentation, ideally by the time someone is brought in onto your ward, or if you're being asked to come and assess this patient, so our approach should always be the ABCD approach. And remember, we said that most of these patients will not have any particular complaint. They will be generally okay. So no need to be worried. But however, you'll still have to go ahead and do your airway assessment. Most cases might not find anything. And then you proceed to do your B assessment. And here in the B assessment, we want to have a comprehensive assessment. Reason being that the patients presenting to you might already be having complicated DVT. So there are particular things in your breathing that are going to be pointing towards that. For example, if we have an increased work of breathing, if we have a profound low oxygen saturation, then you know that this patient has a high probability that they have also gotten a PE. In our circulation, for those that are still very stable, everything might still be okay, but we still want to be able to record every detail about the patient circulation. Remember to record your heart rate, record your heart sounds, and then significantly for patients whose predisposition might be having a DVT in the upper limb, because we see normally in the upper limb, normally it's either superior vena cava obstruction syndrome or thoracic outlet obstruction causing compression to our subclavian vessels. So these patients might also appear to be having bilateral dilated neck veins. They might have facial swelling in addition as you're assessing at your circulation, and also they might appear very flat. So when you see this, think about the possible DVT. Sometimes you might have missed it, you might not have thought about it, but if you find this in your assessment, then think about the possible source being in upper arm extremity. In disability, you might not see much if a patient is very stable, but for those who have complicated, their GCS might be low. So remember to still comprehensively still assess your disability. Then what will be outstanding will generally be in your exposure. Help me go to the next slide. And in your exposure, you're going to clearly see that the patient has that unilateral limb swelling, and always remember to compare them to the other sides. This swelling begins to be significant if you're able to measure with a tape measure and you get a circumference and there is that increase of about 3 centimeters, that becomes significant. If you palpate, you should try to palpate along the anatomy of the veins, how they flow on the body, and you'll discover that this patient reports tenderness. You're also able, if it's a patient who is not completely awake and able to give you feedback that now that is painful, you can be able to see that this patient is wincing in pain. So indicating that they're having tenderness at that point. The limb might appear erythematous. And as it's progressing to being more severe, then you might also see superficial vein distension, and collaterals, the surrounding collaterals might also become obvious. You might also appreciate the pitching edema. Still with the presentation, as I said, for those that are not yet complicated, everything might look okay. But then for this patient who is bed-bound, critical in the ICU, you also want to go ahead and appreciate our pulses. So appreciate the pulses at the popliteal fossa, and also appreciate the pulses at the dorsalis pedis. So when you don't perceive or you don't appreciate these pulses, that means that now it's getting more complicated, and we have a high risk of this limb even turning gangrenous. For patients that will have a critical presentation that might warrant you not even just manage alone, needing you to have all hands, I mean extra expertise to help manage this patient. For patients that already are going to present to you with obvious venous infection, and this venous infection could be either you have the complete obstruction from the thrombi, or because of the surrounding edema, the pressures in that limb begin to increase, and now this compromises blood flow to that limb. So we begin to have ischemia. So this patient will have severe leg pain, swelling, and the leg will appear really cyanotic. And if you delay to identify this and intervene, most probably this patient is going to progress to getting a wet gangrene. The next slide shows an image of what that looks like, and the medical term normally used that is phlegmasia. So you can see in this picture how extensive this looks, and it's just a matter of time before it gets more gangrenous from that. And still, while you're completing your exposure assessment, try to look for any obvious signs that might point towards a malignancy, or if it's a female patient, look for any obvious signs of someone being pregnant, because we don't want to miss out these things. These are some of the things that are going to be able to guide you on how to investigate and exactly what you're going to add as you're managing your patient. Initially, we have what we call the Wells criteria, and this one will help us. If you're all able to see, they are relying on the symptoms and the signs that a patient will present with, and each has a particular score. So at the end of your assessment, because sometimes you may not readily have investigations, or you're trying to determine if this is a high probability DVT patient or it's a low probability. So each particular point there has a score. So every time you have a score that is less than 2, chances are high it might not be a DVT, and it might not really warrant you to go ahead and do more aggressive investigations. However, if your score is above, then you want to go ahead and do more investigations to confirm this diagnosis and then begin your treatment. Though still majorly, you can still rely on your clinical exam and the history finding to be comfortable that this is a possible DVT. Then things that can support you, bedside. We're in an era where we are having more of these things readily available at our bedside. We have the pregnancy kits as rapidly available. You're able to do it, and within a short time, you're able to know if this woman is pregnant or not. You should be able to run some few labs. You'd want to get your CBC done. You'd want to estimate your hemoglobin. You'd want to get coagulation studies. It's important for us to get the renal function test, because these ones will also be able to tell you about more of the comorbidities in the patient if they have renal failure, plus the particular choice of treatment that you're going to give the patient will determine if your renal functions are normal. D-dimers can be done. However, it is important to note that if it is negative, you're going to be comfortable that this patient doesn't have a DVT. But if it happens to be positive, it is not automatic that it's a DVT, because as we know, there are so many other causes of having an erased D-dimer. For example, if someone is pregnant, if someone has a malignancy, if someone has just had trauma or they are post surgery. or if they have any ongoing inflammatory process in their system, then they're going to be having high D dimers. So you see how it's not really specific to help you say that 100% sure this is an actual DVT. So if it's high, then it's going to direct you to other tests that can be done. And on the bedside, we have ultrasound. And with the ultrasound, you're appreciating if the veins are compressible, because we know when we have a clot, it's going to occlude. And in your assessment, you're not going to appreciate the venous flow in that limb. Then there is an image to show what that will look like. And you see that this ultrasound is really going to be helpful to you. It's going to be timely and it's not invasive. However, if you're not able to conclude from your D dimer, you can't make a conclusion from your ultrasound findings, and you have a very, very high index of suspicion, then you'd want to go ahead and do the CT venography. This is more invasive because you also have to rely on injecting the patient with contrast to find out if you actually have a DVT. The next slide just shows the two vessels. We're able to appreciate the femoral vein and the femoral artery. So the upper image is what you expect. The first one is normal. When you compress, the vein disappears. Then the image below, you can appreciate that even with your compression, they both stay patent, indicating that there is something inside that vein occluding that vessel. So we've confirmed that our patient has DVT, and then we want to manage. Our goals of management are going to be to anticoagulate this patient. What we have available will depend on the patient profile. We commonly begin with the heparins, either low molecular weight or unfractionated, and here we want to give it in relation to the patient. So we are using the patient's weight, determine the dose. We want to give it for a minimum of 5 to 7 days. And depending on still the patient profile, you either want to introduce warfarin in, or if there is no contraindication, or if there is no any confirmed, if there is no, because remember in our investigations, we said you're going to also get your renal function test. If a patient doesn't have any indication of renal disease, then you want to go ahead and use other modalities like the rivaroxaban. The only challenge to this is that it's expensive, yet we know that with our warfarin it is readily available. And when we choose to use the arm of using the heparin and then introducing in warfarin, this should be done at either 24 hours or 48 hours, because we know warfarin takes time to reach its therapeutic levels. So you introduce it, and remember to also look at your INR, because those values you get are going to determine what dose you're going to use. We know if our INR, the therapeutic values, if it's above 3 and we have a high risk of bleeding, then we might have to reduce on our dose. Or if our INR happens to be below 1, below 2, because therapeutic range is 2 to 3. So if our value is below 2, then that means we have a higher risk of this patient clotting, and therefore we want to be able to give at a higher dose of warfarin. Then for some particular cases where we think that our DVT is extensive, or if we are able to attribute it to a particular malignancy, we might even want to give the course of the heparin for more than the 7 days. For cases where we're able to identify the cause and reverse it, then we know that we can give our course of treatment for a minimum of 3 months. Then for those particular causes where we can't be able to identify exactly what is causing it, if it's an idiopathic DVT, we might want to go to almost 6 months or longer if it's a malignancy, or if a patient is prone to having more continuous hypercoagulable states, then we want to still give beyond the 6 months. Then other things will really be supportive. If a patient is in pain, we want to give. Preferable is our NSAIDs, but we know, given that this patient has a high risk of bleeding, we don't want to go beyond 3 days of NSAIDs. So still the choice of our painkiller will be determined by the patient profile. And then other things we can do for these patients. Remember case I talked about where we have ischemia and we have like the phlegmasia developing, then you might want to also do fasciotomy for this patient because they have a high risk of the gangrene forming and then eventually losing that limb. Where we have a contraindication to the anticoagulants, then we have other modalities coming in. And by the time we are thinking of these modalities, we should be having a specialist to do this. So modalities like the thrombolytics, these will only be applicable to just a specific group of patients. So for patients who have an age below 60 years, or if we think they have the phlegmasia, as we have confirmed that it's there, and they have a risk of getting gangrene, then these ones, we want to give them the thrombolytics. However, note that the risk of bleeding in the thrombolytics is even much higher than when we use the other heparins or the warfarins. Then other things we can do if there is still a contraindication to the drugs, then surgically, they can go in and do a thrombectomy, or also using the intravena cover filters. However, these ones also come with their complications. In case the filter gets clogged, there is still a high risk of getting the DVT again, and also a risk, because now you're having a higher chance of clots forming, also being sent to the renals, and eventually you also have your renal failure. And also important to note, even if you're given the filters, there is still an indication of putting this patient on the anticoagulation. So as I mentioned, clearly, if you've made the diagnosis, you need to treat. The choice of treatment you're going to use will depend on the patient profile. Then for other particular patient groups where you identify that they do not actually have the DVT yet formed, but they have a risk of forming, then we want to give them prophylaxis to prevent them from forming. And commonly in our setting, we see most of our critically ill patients in ICU, they will need to be on DVT prevention prophylaxis. And you can help me go to the next slide. And for the other patients, still, based on our profile, it will depend. If it's a patient who you've assessed and they don't have any other complication, patients who have been given the rivaroxaban, clinically stable, you could treat this one as an OPD case. Then for these particular patients where you have given the heparins and they have a high risk of bleeding, or if they have any comorbidities, then you don't want to send these patients home. So you'd want to admit them, continue observing them and monitoring them, and then running some coagulation studies on them. So for the complications, as we mentioned, there is a risk of getting a PE from a DVT. There is a risk of getting the phlegmasia. And then we also have what we call post-phlebatic syndrome. It is common when we get DVT, especially if we undertreat it or if we don't give adequate doses of anticoagulation. And ultimately, chronic DVT cases will progress to chronic venous insufficiency. Thank you for listening.
Thank you. Thank you so much, Dr. Linda Grace, for those very insightful discussions in assessment, investigation, and management of a patient with DVT. I'm going to go ahead and welcome questions. If anyone has questions towards Dr. Linda Grace's discussions, I'm going to welcome them right now. You can also feel free to post your comments and questions in the chat box, and we'll be sure to get them answered. You can just raise your hand in case you have a question, and I'm going to go ahead and welcome a question from Bernard Onyango. Oh, I had seen his hands up, but if you have any question. Okay, Duncan, you have a question? All right. Maybe I can call on Dr. Mary Ellen Lyon if there's any outstanding question that was posted, or there's any comment you'd want to give towards Dr. Linda Grace's discussion.
There's a question here whether sickle cell disease is a risk factor for DVT and how that works. The person asking notes they've seen quite a number of sickle cell patients with DVTs.
Yes, thank you for that. So as we recall from our virtual triad, sickle cell predisposes us to a state of hypercoagulable and also stasis. So those two will definitely make the patient be at risk of getting a DVT.
Thank you.
And there's also a question, if I may add, about the relationship between DVTs or the risk rather in patients with cirrhosis, liver cirrhosis.
So I'm not sure if I put in the question right. Is it a relationship between the two, or how we can make the diagnosis?
Just says talk about DVT in patients with liver cirrhosis. Does whoever asked the question, Shamina Munaba, want to clarify?
It's more of like, I wanted to talk about the management of DVT in patients with liver cirrhosis, because we already know they're having coagulopathies. So how best would you now manage them if they're having this DVT? Thank you.
Thank you for the question. So as I had said in our management strategy, is that for each modality we have, we are looking at the patient before us, what is going to work for them and what is going to work against them. Remember, we said that for these anticoagulants, we have a high risk of bleeding. So if in our patient profile, we see that whatever modality we are going to give, they are going to bleed, then we want to think of other things like, so if it's a patient who has liver cirrhosis, but their renals are completely okay and they can afford, then the rivaroxaban becomes a good molecule for us to give this patient. However, if they can't afford, then we are thinking of other modalities like I mentioned. We'll have the other experts like surgical interventions coming in, considering either the filters or the thrombectomy. Thank you.
And thank you so much. I'm going to kindly ask that we can go on to the next activity, but I also want to welcome Dr. Ddungu Henry, the oncologist who has joined us, and he will be discussing with us the causes, clinical assessment, diagnostics, and emergency management in a patient with pulmonary embolism. So we are glad to have you, Dr. Ddungu, join us. We're going to go on to the next case presentation that will be done by Dr. Nyakubaho. You have 10 minutes to present to us the case, and then after we shall welcome a few comments or questions towards the case that will be presented. Over to you, Dr. Nyakubaho.
Thank you very much. May the host kindly allow me to share my screen. Okay, thank you very much. Yes, so I'm going to present the case on pulmonary embolism. Once again, my name is Dr. Ampuriire Nyakubaho. So here we have MC. She came in with 2 months of generalized difficulty in breathing, generalized body swelling, orthopnea, PND, non-productive cough. These symptoms worsened 3 weeks prior to admission. She was initially managed 1.5 weeks, 1.56 before in a peripheral hospital, where she was managed for decompensated heart failure and pneumonia and was discharged and in breathing. Body swelling, anorexia, and general body weakness. She also reported 4 episodes of hemoptysis, no reduced urine output, no night sweats, no weight loss. She also reported that she smokes cigarettes and she has a 35-pack-year history of smoking. She takes cat and no history of alcohol use. In the ABCDE, her airway, she was in respiratory distress. She was breathless on talking and was occasionally coughing. Breathing, her respiratory rate was 35 breaths per minute. She was tachypnic. Chest was asymmetrical due to edema. She had an asaka, but edema on the left was much more than that of the right. She had bronchial breathing on the right. The chest. In her circulation, she had cold extremities. She had elevated JVP. Her blood pressure was 116/78. Capillary refill was 3 seconds. And she had a positive hepatojugular reflex. In disability, her GCS was 15 out of 15. Pupils were equal and reactive to light. Neck was soft. She had an intact cessation. RBS was 10.3 millimoles per liter. The patient was unable to walk and was being moved around in a wheelchair. For exposure, the chest was asymmetrical once again due to the edema on the left being more than that on the right side of the body. The patient was obese, so we couldn't assess for any organomegaly in the abdomen. And the left side of the body was visibly more edematous than that of the right side. In our ABCD management, we realized that it was the breathing that had most of the issues because she was saturating at 80 on room air. So we put her on 5 liters of oxygen per minute. And after 15 minutes, the respiratory rate had decreased to 30 breaths per minute. And her SpO2 had increased to 95% on 5 liters of oxygen per minute. Yes, so we did some investigations. We did a CBC, we did thyroid function tests, APTT, INR, RFTs, LFTs, D-dimers, ECG, EKG, chest X-ray, CT scan, and abdominal ultrasound scan. So on the CBC, the absolute neutrophil count was 20.1, upper limit being 7.5. MCV was also elevated. The thyroid function tests, T3, T4 were low, and TSH was slightly raised. APTT was 119 seconds, which was raised. RFTs were normal. RFTs were slight, AST being above the upper limit, ALT being 7.2 above the upper limit, GGT being 6.8, ALP being 2.9 above the upper limit, and there was also raised direct and total bilirubin levels. The D-dimers were 10 times the upper limit of normal. On the echocardiogram, we saw a dilated cardiomyopathy with biventricular failure and volume overload with moderate pulmonary hypertension. EKG showed sinus tachycardia with a non-specific intraventricular conduction delay. Chest X-ray revealed a massive left-sided pleural effusion. Chest CT scan revealed moderate left-sided empyema with marked consolidation. Left-sided empyema with marked consolidation collapse. Severe embolism of the left pulmonary artery, both lobar and segmental arteries associated with peripheral wedge-shaped lung infarct. There was an uncomplicated right pleural effusion with basal-predominant compressive lung atelectasis. Abdominal ultrasound showed mild ascites with hepatomegaly. So this was the EKG, and most importantly, this was the CT angio. Let me see if I can show you the filling defects. So when we look at this slide here, we see the left pulmonary trunk. I don't know if everyone can see that. The left pulmonary artery here. And because there is contrast, blood is supposed to appear white, but we look at this hypodense lesion here, this hypodense opacity. That was the filling defect, and it goes ahead to also be in this slide, as well as this one here. Yes. Then by then, our differentials, we came up with PE Also sepsis with the focus being the lungs, acute decompensated heart failure, secondary dilated cardiomyopathy. And we wanted to rule out carcinoma of the lung because when we did the thoracocentesis, the fluid was bloody. So we also took off samples for pleural fluid analysis. We did thoracocentesis, and a thoracostomy tube was inserted. We gave IV PISA, IV levofloxacin, IV fluids, subcutaneous Clexane, Lasix, oromorphine, and oxygen therapy, captopril, carvedilol, and dapagliflozin. Currently, the patient is still on ward and is showing marked improvement. Thank you very much.
Thank you so much, Dr. Nyakubaho. I think that was a very good presentation, very typical for PE, and I think gives a very good picture of patients who present to us with pulmonary embolism. And I know that a lot of insights have been gotten out of your presentations. And now I'm going to go ahead and welcome any questions that anyone has towards the Dr. Nyakubaho's presentation. A very insightful case. Anyone ask a question, you can feel free to raise your hand and we shall give you opportunity to ask your question. Yeah, meanwhile, I'm going to ask Dr. Mary Ellen if there is any outstanding questions in the chat that you've identified, or Dr. Kalanzi.
There was a question about the standard dose of the low molecular weight heparin in prophylactic prevention of DVTs and whether or not the BMI alters that dosing.
All right, I think that will be answered in our next, it will be answered by our next expert. Okay, Dr. Kalanzi, do you have any question towards the case or any comment?
He indicates he does not.
All right, I believe the questions that are in the chat are being answered.
I'm sorry, there is a question asking if we could, either DVT or P, if we could discuss the nursing management to some degree of these patients.
Okay, I think that has been added. Okay, I think I will go on and welcome Dr. Ddungu, who shall be taking us through the next discussion. You're welcome, Dr. Ddungu.
Hello, how are you?
We are fine.
You can see me?
Not yet.
Not yet. Okay, we can now see you.
Or at least you can hear me.
We are hearing you loud and clear.
So thank you very much for inviting me to be part of this. And I thought we can make it probably as simple as possible, including assuming that we answer questions. But I don't know what I need to share or not. I can give you a few slides just to highlight, also give a highlight of what happens, but as you know, there are a number of things that need to be discussed when it comes to emergency management of pulmonary embolism. Am I allowed to share?
Yes, doctor, you have the right to share your slide.
So you're seeing that?
Yes, we are seeing your slide.
So mine is just going to be very, very simple so that we allow for an open discussion, because a presentation that has ended on deep vein thrombosis I'm imagining it has covered almost everything, because pulmonary embolism is just part of the spectrum of diseases. So when you talk about DVT and then pulmonary embolism, we talk about VTE, venous thromboembolism. And, you know, there are quite a number of factors that could be associated, but the commonest risk factor for pulmonary embolism is having a clot from somewhere else. When you have a thrombus in a deep vein somewhere, which vein can lead to the heart, and the heart can pump blood to the lungs, then it means you're at risk of getting a DVT. I just want to emphasize the point that 1 in 4 people globally die of conditions related to blood clots, whether in the arteries, whether in the veins. And you guys who work in the emergency department, I think you've seen quite a number of people with acute stroke. You've seen people with coronary artery disease. All these are coming in because of blockage. And also to emphasize to our colleagues who handle patients after the emergency that 60% of blood clots are actually hospital acquired. Someone will come to the emergency department not with a PE or DVT, but then they leave home with a PE because of the factors that are associated with hospitalization. So as colleagues in medicine, we need to be aware, and whenever a patient comes in, we should be able to do a quick assessment to find out if actually they're at risk of getting a blood clot or not. Okay. The classification of pulmonary embolism is based on the clot location or hemodynamic compromise. Many of you have heard about saddle PE, which refers to a clot located in the main pulmonary artery or the bifurcation. Saddle PE does not necessarily translate into a massive PE. I hope you know that. And mortality rate related to saddle PE is just about 5%. Not just about, but it's not as big as we used to imagine that it is. So lobar segmental and subsegmental pulmonary embolism describe clots that are located in these pulmonary arterial branches correspond to the anatomic lung, lobe, segment or subsegment, respectively. The reason why we talk about classification of pulmonary embolism is because it has implications in its management. So the American Heart Association and the American College of Chest Physicians, they define pulmonary embolism into 3 basic categories. Massive pulmonary embolism, which is defined as persistent hypotension of systolic blood pressure less than 90 millimeters of mercury, lasting more than 15 minutes, or requiring inotropic support. If someone has no pulse or they are bradycardic with less than 40 beats per minute, then such people will fall into the category of massive pulmonary embolism. And then for the submassive pulmonary embolism is when you have pulmonary embolism without systemic hypotension, but with right ventricular dysfunction, as based on either imaging with a CT, pulmonary angiography, or transthoracic echocardiogram, or elevated biomarkers such as the brain natriuretic peptide, the N-terminal pro-BNP, or elevated troponins. So when someone comes in and they have a PE and they're falling within that category, then you can say this could be a submassive pulmonary embolism. Then we have a category of low-risk pulmonary embolism, which is an acute PE without hemodynamic instability and without right ventricular dysfunction. I don't know which one is the most common. You guys will let me know who work in the emergency department. but I think low-risk pulmonary embolism is quite common. As I said, I'm not going to get into the details of, do this and this. I'm looking at a situation of an emergency. To diagnose pulmonary embolism, you need a very high degree of suspicion because many times, the symptoms are non-specific and the diagnosis becomes extremely challenging. There are many people who have been treated as, acute lobar pneumonia or community-acquired pneumonia when actually they have pulmonary embolism. So the symptoms tend to be non-specific. But the classic presenting symptoms are pruritic % of people, and then dyspnea, especially dyspnea at rest. Someone is at rest, but they're feeling very, very short of breath. And this occurs in up to 50% of patients. So these are the cardinal presenting symptoms of a blood clot that is sitting in one of a patient's pulmonary arteries. In up to 20% of patients, they might present with hemoptysis. And this is as a result of pulmonary infarction. We have seen a number of cases that present with syncope as an initial presentation. And this is especially in people who are having hemodynamic instability and massive pulmonary embolism. Physical examination is very, very important, but we focus mostly on the cardiovascular examination, looking out for the heart rate. Either someone has tachycardia or hypoxia with a new or increasing oxygen requirement from baseline, assuming that you had a chance to see them from baseline. But many times in the emergency department, we are going to work with a high degree of suspicion. An elevated JVP with a hepatojugular reflex, right ventricular heave, or a loud P2, especially if there is significant right heart failure, are common manifestations for patients, especially with hemodynamically significant pulmonary embolism. Lung sounds are often unremarkable, but the patient may appear to be in respiratory distress, and some of them look really anxious when they have pulmonary embolism. Again, as I said, I will not go into the details of these scores, but what I want to bring out is we need to be guided as clinicians. These risk prediction tools, they help you to identify patients with VTE and also help to stratify the risk of short-term morbidity and mortality in patients with VTE. The most common tools for prediction of VTE include the Wells criteria. I think many of you have heard about this. We have the Wells score for DVT, and then the Wells score for pulmonary embolism. They've tried to do a number of revisions. We have the Geneva score, the pulmonary embolism rule-out criteria. All of these are available, but not all of them are validated. I think the one that has been worked on really well is the Wells score. The aim for each of these tools is to provide an objective method for estimating pre-test probability of having a pulmonary embolism into either low, intermediate, and high risk categories. I'll repeat this. We need to estimate the pre-test probability of having a blood clot in the lungs. These tools help encourage the practice of evidence-based medicine rather than ordering unnecessary studies, as I see these days. You know, any patient who goes anywhere will come out with a CTPA. Almost everyone. Any person with a D-dimer that is 501 has a PE, when normal is up to 500. So we need to be careful on how to, identify people who need further evaluation, basing on the knowledge we have and basing on our degree of suspicion. So as I said, Wales criteria is one of the most extensively studied and well validated, and thus used more frequently. There's also the prediction of short-term morbidity and mortality, which is of clinical concern. So the PE severity index, what we call the PESI, and the simplified PESI are most commonly used to predict short-term morbidity and mortality with pulmonary embolism. These help us to understand what will happen next. But you as an emergency care physician, you'll be able to help identify who is at risk, start them on treatment, and then they move for long-term care. You can officially ignore this. This looks like the Geneva score and then the Wales score, which has various points. For example, PE is most likely diagnosis. You score that person 3. When you say signs and symptoms of DVT are present, you score 3. Heart rate is more than 100, 1.5. In previous 4 weeks, there has been immobilization, 1.5. And if there's active cancer or hemoptysis, then you give them 1. They almost look the same as 1 in the Geneva score. So this is the original and simplified pulmonary embolism severity index that you can look around and read to understand how it helps. The parameters that are used to predict severity. In terms of lab testing, I wanted to emphasize a few issues here. The cardiac troponins may be elevated, and if they are, they could suggest myocardial injury, because we know that during PE, the myocardium can become ischemic and thus release troponins. And in combination with BNP, troponin has found a useful marker of right ventricular dysfunction. So in the emergency department, please look out for that. A D-dimer test is now known to almost everyone. When I studied blood medicine many years ago, we used to have a simply D-dimer qualitative test. But now we have a quantitative test to assess for the fibrin degradation product called the D-dimer. It is used as a surrogate marker of fibrinolysis and is expected to be elevated during a thrombotic event. A D-dimer can be elevated in various conditions, such as pregnancy, postoperative states, and malignancy, which lowers its specificity. So not all elevated D-dimers indicate a blood clot. However, in combination with a low pretest probability for PE, a normal D-dimer rules out pulmonary embolism due to its high sensitivity and negative predictive value of up to 100%. So by this, it means if you have a patient with a high pretest probability for pulmonary embolism and they present with a high D-dimer, then the chances are so high that this patient could be having a clot in the lungs. So you go ahead and confirm. If the test is negative and you had a low pretest probability, because of its high negative predictive value, you can confidently say this patient does not have a blood clot. I hope that is clear. Okay. So in terms of imaging, a number of them can be done. Venous ultrasound duplexes are the commonest. Ultrasound of the lower extremity is useful when you're evaluating a patient for PE. If I were you, before I send a patient for CTPA, I would imagine that in the emergency department, there's an ultrasound scan. I would start with that to see if actually this patient has a clot in the lower limbs before sending for CTPA. The goal is to find non-compressible veins, suggesting vessel occlusion. So ultrasonography in PE supplements the diagnosis of PE by identifying a source. As we said in the beginning, a clot in the lungs is usually a clot that has moved to there. It's an embolism. So you need to find out where could it have come from. If you find that someone has an extensive clot in the lower limbs, then you don't even, technically speaking, you don't even need to go and do a CT scan because the treatment is going to be the same unless if they are unstable. So a negative venous ultrasound rule out the possibility of a PE, that a clot could have formed in the legs and moved away. By the time you come to compress, there's nothing that you are going to find. Echocardiography, especially the transthoracic echocardiography, is commonly used in evaluating a patient with suspected PE, but it does not diagnose PE. Rather, it aids risk stratification. We don't use echo to diagnose PE. When you go to read about the Makerere sign, which means decreased right ventricular free wall function with apical sparing, the cardiologists know this, is specific for PE. So a cardiologist or a good person who is doing an echo, if they talk about a Makerere sign, then that is specific for pulmonary embolism. For a long time, we used to teach or be taught that the gold standard is pulmonary angiography. CT pulmonary angiography has largely replaced the traditional gold standard. It is less invasive, it is quick, and currently most institutions can access it. So we use CT pulmonary angiography to help confirm a suspected case of pulmonary embolism. Even when it is negative, it can be helpful in identifying other etiologies responsible for hypoxic failure, such as interstitial lung disease, pneumonia, or effusion. Ladies and gentlemen, can you hear me?
Yes.
Yes, we can hear you.
Yes, doctor.
Thank you. So again, to talk about management, I'm not going to talk about the specifics, but I'll answer the specifics of management because I understand people have different questions. But as a general rule, all patients with a high pretest probability or confirmed PE should be initiated on anticoagulation. And the empiric early anticoagulation been associated with increased mortality for patients with acute pulmonary embolism. Ladies and gentlemen, the mainstay therapy for patients being admitted is unfractionated heparin. I hope you can take that. The mainstay therapy for patients being admitted is unfractionated heparin given at a dose of 80 units per kilogram bolus, followed by an infusion at 18 units per kilogram per hour bolus, okay? And then you are going to monitor. But I know many of you out there have not even seen unfractionated heparin. Is that correct? The reason I'm saying this is because, you are going to get a patient with PE, but they also have chronic kidney disease. And some of these medicines, you can't use them in CKD. Most people who come in with pulmonary embolism have other comorbidities that might be a contraindication to other treatments. So the mainstay is that. All, let me take you to make your life easier. Weight-based dosing for low molecular weight heparin, such as enoxaparin. Whenever possible, especially when a patient is hypoxic, give supplemental oxygen. And for massive PE and submassive PE, patients with comorbidities should be managed in the intensive care setting. Usually we talk about medical intensive care unit, not the surgical intensive care unit. So they should be in the MICU or MICU to ensure that they're monitored. And also to know that managing patients with acute pulmonary embolism requires physicians from varied specialties, and it also needs coordination of care.
Dr. Ddungu, you're muted.
So, okay. Yeah, I was muted because I was responding to something here. So we need coordination of care in a very time-sensitive manner so that, you know, a patient is given the best treatment possible. So again, when you're looking at low-risk PE, the choice of treatment of low-risk PE is anticoagulation. And patients with low-risk PE should be considered for early discharge and may not need admission. I have seen many people, because they found some small clot in the lung somewhere, and the patient is admitted for weeks. They're even sent to ICU, when actually they don't need to be in ICU. Decision to admit or not to admit should also rely on how immediately patient would have access to, you know, the novel anticoagulants or low molecular weight heparin once they're discharged. Currently, the novel or the DOACs or NOACs are the treatment of choice according to guidelines. But I'll say that with a caveat that use them or prescribe them if you have the clear instructions to give to the patient, okay? In patients with extremes of weight, in patients with the antiphospholipid syndrome, vitamin K antagonists remain the agent of choice. So if someone comes to you with 300 pounds, or they have antiphospholipid syndrome, or they have a clot in a weird place, like, you know, a superior sagittal sinus thrombosis, vitamin K antagonists are the treatment of choice. Treatment for a first provoked VTE or even first unprovoked is now 3 months. We no longer talk about 1 month or 6 months. The preferred is 3 months. And for PE, when patients present with cardiac arrest or hemodynamic instability, they should be in the intensive care unit. And it is now widely accepted that we can try reperfusion strategies in such patients. And the reperfusion strategies are quite many, including use of thrombolysis with medicines such as alteplase or systemic thrombolysis. However, I mean, other forms of systemic thrombolysis, keeping in mind a risk of up to 20% of major bleeding, okay? Including intracranial bleeding. So don't just say that, oh my God, this is a PE massive, let's give alteplase or let's give urokinase or streptokinase. You can give them, keeping in mind that there's a very high risk of bleeding. So as I end, I wanted to really bring out these key clinical points, that pulmonary embolism is a common diagnosis and can be associated with recurrent venous thromboembolism, bleeding due to anticoagulation therapy, chronic thromboembolic pulmonary hypertension, and long-term psychological distress. Many people who have had a blood clot in the lungs, they tend to have a lot of psychological distress. There are many of those who continue to be on oxygen at home because of the complications such as chronic thromboembolic pulmonary hypertension. A minority of patients who are evaluated for possible PE benefit from chest imaging. So not everyone will need CT pulmonary angiography. Again, to remind you that initial treatment is and should be guided by classification of the pulmonary embolism as either high risk, intermediate risk, or low risk. And that most patients have low risk pulmonary embolism, and their care can be managed at home with a direct oral anticoagulant. I'm emphasizing this because I'm imagining that my colleague who talked about deep vein thrombosis talked about the virtuous triad. That triad is extremely important, and it is the one that drives us in preventing blood clots. So, someone is talking? Okay. So most patients are admitted even when they have a clot in the lungs. Most patients, I said, have low risk pulmonary embolism. But for patients with acute PE, they should receive anticoagulants for at least 3 months. Usually say the physician has, that discretion to continue. The decision to continue treatment indefinitely depends on whether the associated reduction, the risk of recurrent venous thromboembolism outweighs the increased risk of bleeding and should take into account patient preferences. And lastly, patients PE to assess for dyspnea, functional limitation, which may indicate the development of this condition called post-pulmonary embolism syndrome or chronic thromboembolic pulmonary hypertension. I'm going to stop here and welcome questions.
Thank you so much, Dr. Ddungu, for that elaborate discussion. I think lots of key things have been said in your discussion. One that I noted is that majority or many of the cases of PE actually are hospital acquired. And what does that mean?
60%.
60% is hospital acquired, and that means that we should not stop assessing patients for PE only in the emergency department, but even in the holding wards, we should be taking keen interest in ensuring that we are doing assessment for PE and also making initiative to actually prevent it from occurring. And the other comment that you made is whether we really know the statistics about the low risk PE, then the submassive and massive. I would want to think that maybe when the low risk PE actually go unnoticed in many cases. Maybe we need to be taking keen interest more, especially in patients who might be having risk factors to PE. And then you highlighted actually the fact that point of care ultrasonography could be a very good adjuvant in diagnosing our patients of pulmonary embolism, though the key future might be a bit challenging for many to understand. But I believe with the increase or with availability of point of care ultrasound scan, maybe we shall get good at it and have our diagnosis made promptly and patients managed optimally without them having to get complications or even die from pulmonary embolism. And then you also cited the dosaging of low molecular weight heparin. And the question that I had in that regard is about the patients who are obese. You made mention that the initial bolus dose is 80 units per kilogram. And then we go on to do an infusion of 18 units per kilogram. And the question that struck me is how about those that are obese, and is there not a maximum dose for the patient? Maybe you will help highlight that. Yeah, those are the comments that I had. Otherwise, I'm really very thankful.
Maximum dose is not there. When you're using unfractionated heparin, you're going to give according to the weight of the patient.
Oh, okay. I think that answers my question.
But people should understand it. I'm talking about unfractionated, not low molecular weight heparin. that was traded as Clexane, a brand name. So I'm talking about unfractionated heparin that is mostly used, in dialysis and other places where they need to thin out blood. Next question.
In case someone maybe just serving the low molecular weight available, how do they go about the dosaging for the obese patients?
So that has been a controversial thing, but we still believe that you are going to give them according to their weight.
Okay.
You are not going to say that because Ddungu is 99 kilos and I cannot give that. So now the evidence is there that we give according to the weight of that patient, the low molecular weight heparin, and then we continue with either vitamin K antagonist or not. When you are going to use DOACs, ideally don't need bridging. They start working almost immediately, and they can continue working like that. But for low molecular weight heparin, we should be giving it according to the weight of the patient.
Thank you so much. I'm going to open up the discussion. Any question, comments towards Dr. Ddungu's discussion are welcome at this point. We are privileged that we have him, and I'm very sure that he will be able to answer all your queries. Feel free to raise your hands, and we shall give you the opportunity to ask your question. As we do that, I'm
asking what is the pathophysiology of increased D-dimers?
I have a question.
Pregnant.
I have a question.
Oh, okay. Go ahead. Jonathan, go ahead and ask your question.
Thank you so much. I hope you can hear me well.
This is Derek. I have a question.
I hope you can hear me well.
Okay, let's
my question is...
Sorry, I'm going to interrupt because I'm having two people speaking at the same time. Let us hear from Jonathan. Go ahead and ask your question, then we shall give Derek opportunity as well.
All right, thank you so much. My question is in relation to the low risk PE. Can we still use the NUOX like rivaroxaban or apixaban? For the recent study I read from the European Society of Cardiology, it was talking about the non-inferiority between the NUOX and the low molecular weight kind of heparin. So in Uganda, can we still use, in the event that probably the patient is resource constrained and cannot be able to afford, let's say, the low molecular weight heparin or anything of that kind, can we put her on probably the NUOX? Back to you, the moderator.
Thank you. I don't know what Dr. Ddungu prefers. Would you prefer answering the question per question?
Well, I'll respond immediately.
Okay, go ahead.
First of all, to clarify that actually DOACs are more expensive than... it looks like your team speaks anytime they want.
Kindly mute. We shall give you the opportunity to ask your question. Go ahead, Dr. Ddungu.
Yes,
Derek, kindly mute.
I was saying that, yes, in low-risk pulmonary embolism, we can use direct oral anticoagulants. But let's not use them in the context that they're the cheapest, because they're not the cheapest. It's cheaper to use the others. When you look at a cost of, say, rivaroxaban per month, is quite high, even when you compare with all the other aspects. So we can use them. To answer you directly, yes, we can use them directly.
All right, thank you. Yes, Derek, go ahead and ask your question.
Thank you so much, our experts, for this wonderful presentation. My question is, thank you, Doctor, for the good elaboration. I wanted you to help me put more hint on massive and submassive PE, some more hint on how on that clarification, stratification, and then also help me put more hint on the pathophysiology of increased D-dimers in pregnancy and what can be done in case there are increased diamonds in pregnancy, what can be done? What's the management? Thank you so much.
Okay, to respond to that, thank you. Massive pulmonary embolism is.
Thank you so much.
Yeah, you can switch off. We've had. Hello?
Yes, go ahead, Dr. Ddungu. I think
I was saying that if someone has massive pulmonary embolism, first of all, these are patients who should not be treated at the periphery. They should be treated by the emergency physicians who will push the patient right away into the best place of care. When a person comes in with suspected PE, how do you tell it is massive? You're going to tell by the degree of dyspnea, by the blood pressure being low, patient has tachycardia. You will assume this patient has a PE, especially if the pretest probability is high, and you start them on treatment for a person who has massive pulmonary embolism. My advice would be, if you suspect it is an acute problem like that, don't use a medicine that is not easy to understand how to give. Either use unfractionated heparin if you're in ICU, or you have an infusion pump, or use weight adjusted low molecular weight heparin while observing the patient. Okay. The pathophysiology of elevated D dimers, you know, as a mother is carrying a baby, there's a lot of placental interchange and, you know, a lot of activity is happening. And the D dimer tends to increase as the pregnancy increases. I can find time and give you more details on the actual pathophysiology, but we should not just say because someone has a D dimer that is about twice the upper limit of, above the upper limit of normal by 50% or something, and we confirm that it's a DVT. We should go ahead and do the ultrasound scan, compression ultrasound scan. And you know, in pregnancy, we don't do PE. So we need to look out for a possible source of pulmonary embolism to confirm. I've seen so many mothers who have been tortured with heparin because they think they have a pulmonary embolism, when actually they only have an elevated, you know, a physiological elevation of their D dimer. So don't just depend on that to treat mothers as if they have blood clots in the lungs. Next question.
Thank you, Dr. Ddungu. Let's get to your Dr. Walter Omodingi's question. Walter, you can ask
Yes, hello. And here. Yes, can you hear me?
Yes, we are getting you. Go ahead and ask your question.
Okay, thank you so much for the presentation. A quick one. There's a scenario where we had a patient with I would relate it to a saddle PE. And when we started him on alteplase, unfortunately, I was not in the ICU at that time to note how exactly it was given. Once they gave, it so happened that I don't know whether the clot dislodged as it was being broken down, and then ended up blocking the pulmonary vessels completely. So unfortunately, the individual passed on just a few minutes after administering the place. Although he had actually been on heparin for like about a week or so, and he seemed to be fairly stable. So when they opted for the alteplase, well, unfortunately, something went wrong. So I'm beginning to understand. Is there a way that these lytic agents can dissolve this clot with the risk of it dislodging if initially it seemed to be stable at some point?
Okay, thank you very much. Well, I don't think, maybe I didn't understand. It is not the dislodging that caused problems, because you gave alteplase because something there was a massive PE, I suppose, and you gave it outside ICU, which is officially illegal. Okay?
ICU.
Pardon me?
We were in ICU.
Okay, you're in ICU.
Yes.
And usually you give outplays when there's expertise for others. As I told you, almost 30% of people who are given thrombolytic therapy will get massive bleeding, including in about 3% getting intracranial hemorrhage, okay? So it's not about dislodging. It is possible that one, by the time you gave outplays, it was too late. Patient was getting where the challenges. But if you gave him or her, and then they got better and then got worse, the thing you think about is massive bleeding, because someone will get massive bleeding. I don't know what you saw on PM, but the most common complication is either you gave outplays when it was too late, patient had already had complications, or they got massive bleeding. Next.
All right, thank you. Yes, let's hear from John Baptist.
Thank you very much for this wonderful presentation. My question is, these patients want to maintain on warfarin for at least 3 months, but we keep monitoring their INR. At what value should we consider stopping warfarin, and what will be the best substitute if we are to continue with anticoagulants?
Thank you very much.
Thank you.
Yeah, that's a very good question as well. Warfarin is a vitamin K antagonist. And I want, again, to educate my colleagues here. There's been a tendency of people saying that, oh my God, you're on anticoagulants, don't eat. They tell patients, even those who are on rivaroxaban, apixaban, they tell them don't eat greens. Maybe let's learn it from here today, that when you're on direct oral anticoagulants, they don't interact with any food, and they don't interact with most of the medicines. However, vitamin K antagonists, including warfarin, they are driven by availability of vitamin K-dependent clotting factors. So how do you know that someone is in the right window? Indeed, we monitor the patients using a prothrombin time reported as an INR. So you order for a prothrombin time, or what you call an INR, but INR is just a reporting. And the aggregate value should be between 2 and 3. Anything 2 to 3 is considered therapeutic. If someone has, for example, an INR of 4 or more than 4, studies have shown there's good evidence that their risk of getting bleeding from anywhere is high. The risk is high. So we tend to keep the dose so that the INR is between 2 and 3. If someone has a persistently low INR, despite you increasing the dose, most times it is as a result of having vitamin K deficiency, especially if you order them never to eat anything that has vitamin K. It will be difficult for them to control. But INR should be 2 to 3. And you don't have to do INR every other day. We do INR the first week of starting treatment. And then after that, we can choose either to do every 2 weeks or every 3 weeks or every 4 weeks, depending on how they're responding to treatment.
Thank you.
There's so many hands.
Yeah, there's quite a number of hands. I will welcome Mugumya, Sebastian.
Thank you very much, our dear experts, for this excellent presentation. My concern, I have two. One, in settings where you cannot easily access D-dimer and CTPA, and you're able to do a chest X-ray, what are the cardinal features on the chest X-ray with someone with PE? Then secondly, I would like to be guided or informed on what could be the cause for DVT to be affecting most commonly the left lower limb. Thank you very much.
That's a very nice question. You know, in practice, when I see someone coming in with a swelling of the right lower limb, I am hesitant. If it's a if it's a DVT, then this is a DVT that is provoked by something. Either someone has maybe something compressing, either a lymph node or something, or they have a malignancy, but most clots, for some unclear reason, are on the left. I hope you finish your M.Med or you do research. You can help do research on such things so that and I'm going to work with someone in radiology to start identifying these issues. We don't use a chest X-ray to diagnose pulmonary embolism. And that's why I didn't talk about it. When they talk about the Hampton hump or anything, those are things that are better read about, but clinically difficult to see. I think so far, I've seen, 2 X-rays that have that oligemia. But if you're somewhere you cannot access a CT pulmonary angiography, you cannot access a D-dimer, you are lucky, because you're not going to be confused by a number of things. You're going to depend on your degree of suspicion and say, I think this could be PE. Let me give emergency treatment and refer to where they can diagnose. Next question.
All right, I think I will now allow one question, but also a reminder, the post-session test has been already displayed, so you can be answering as we discuss. Let's hear from Ayimisiwe Johnson.
Thank you so much for the wonderful presentation. My question is, I would like Doctor to clarify on the thrombus-specific thrombolytic therapy and its role in preventing major risk of bleeding. Thank you.
Those are some of the interventional procedures that are done by our colleagues in cardiovascular medicine, where you can go in and remove, especially if you have limb-threatening thrombosis. We can actually use an intervention to kind of, use a catheter-based intervention, the way you do in coronary angiography, to remove that thrombosis. But it's not as simple. So it's done in situations of massive thrombosis, in massive pulmonary embolism. But as you know, it is high expertise that is, I wouldn't recommend to be done in any of the regional referral hospitals, but at a super specialized facility.
Thank you, Dr. Mark, you can go ahead and ask your question.
Yes, thank you very much for this opportunity. Yeah, mine, I'd like to type it in the chat. Like, I wanted the expert to comment on the ambulation in patients with the pulmonary embolism. Because some people theorize that patients with pulmonary embolism, they should be kept in bed maybe till it resolves, because you're risking maybe the clot to dislodge and cause a saddle embolism. So I don't know whether
people don't mix things. You cannot dislodge from the periphery into the pulmonary bifurcation. If you look at how blood flows, it starts at the bifurcation, then goes the other side. It can't come up, okay? Let's first make that one clear. Okay, when a person has a clot in the lungs, has it moved or it hasn't? You don't have to answer this. It has moved, right? It came from one of the big vessels in your lower limbs or in the patient's lower limbs, and it has now found refuge in the lungs. You already have a clot in there. If you keep this patient in a situation of stasis, we have gone back to virtuous triad. Whenever you keep a patient with a limb not moving, you are increasing more clotting. Keeping in mind that the medicines we give, other than the alteplase and others, they don't take away the clot, but they help us from further clot formation. And that's why the guidelines have changed and said, do not keep the patient in the bed, unless if they have submassive and massive PE. Patients with PE, patients with DVT should be treated as outpatients whenever possible. It's the reason why innovation of having pre-filled injections and getting DOACs came into play, so that we keep moving to prevent blood clots. Even a person who has a clot can get a clot. I hope it makes sense. So please, the message is stop telling your patients not to move. Ask your patients to move as soon as they've started on anticoagulation. Next.
Thank you so much. I think we shall allow Emmanuel Segawa.
Thank you so much for the presentation. It's been elaborative. I just want to ask, at what point do we make the decision to change from the low molecular weight heparins to the oral coagulation? At what, yes, anticoagulation.
Okay. So depending on what you are going to use, if you are going to use the Novo or the DOACs, such as dabigatran, apixaban, rivaroxaban, and others, you don't need to switch, because many of these medicines have a very short half-life, and you can start working immediately. But if you're going to use vitamin K antagonists, the recommendation is, one, start them on the day when you are starting the low molecular weight heparin. And the science behind is they take long to act. And also, if you give them by themselves, in the first place, they are procoagulant. So a person can develop warfarin-induced thrombosis. You are treating a clot, then you see their finger turning black because of increased coagulation. So these patients should not be given warfarin by itself, but in combination with heparin. And then once the INR reaches therapeutic level for 2 consecutive days, then you can easily stop the injection and continue with the tablets of warfarin. I hope that is clear.
Thank you so much. I know that there is quite a number of questions about...
Give them my email, they'll send an email.
Yes, so Dr. Ddungu will share his email, and you can feel free to ask him any questions about this topic that we've discussed. Quite common in our hospital, especially if you're working in the emergency department, but also it can happen in the ward, and we need to get well acquainted with how it's approached and managed. I'm just wondering whether there is any very urgent or any question in the chat that Dr. Mary would want to point us to, just 1 or 2, and we can have them answered so that we don't totally close out the people that were asking in the chat.
Yeah, there are 2 that rather jumped out at me. One of them is asking, what are the chances that a superficial thrombosis in the upper limb could lead to a pulmonary thromboembolism, right? Do they need to worry about a superficial thrombosis in the upper limb? And then the other that I think is just so important and very difficult, speaking for myself, elaboration on management of pregnant mother with history of confirmed massive PE in a previous pregnancy, and the management of a pregnant patient with active DVT. I find these pregnant patients quite, so a pregnant patient with a history of PE, and then one where we know has an active DVT. How are we gonna handle that?
Thank you so much for that. I'll start with superficial thrombosis in the upper limb. The chances of it causing massive pulmonary embolism are minimal. They can cause embolism to the lungs, but most times asymptomatic. As you know, vessels in the upper limbs are very small, and especially if you talk about superficial, they are quite small. But you can have people getting thrombosis in the axillary veins that are a bit big, and they can give us significant embolism into the lungs with symptoms. Now, talking about pregnancy and thrombosis, as we know, pregnancy is procoagulant. As a way of protecting a mother not to bleed, etc., they end up actually getting more thrombosis. If a mother has a confirmed clot, not just to say D-dimer is high, but we've confirmed through our suspicion that this patient has a blood clot. The recommendation is to use low molecular weight heparin, not DOACs, but low molecular weight heparin, especially in the first trimester of pregnancy, where we are worried about, effects on the forming organs, organogenesis. There's been a bit of discussion on whether we can use DOACs in the later phases of a pregnancy. The guidelines still say no. It's only done at individual levels after discussing the patient and making sure that the person who is following up actually is an expert in managing this. Otherwise, the current guidelines recommend you, and we here, but on the anterior abdominal wall or on the thighs, but preferably on the anterior abdominal wall. We should give anticoagulation as long as the person is pregnant. If someone had a massive PE before or during pregnancy, and now they're pregnant, it is not a guarantee that they'll have another PE during pregnancy. But since we know that having had a blood clot and you're pregnant, you're now having 2 risk factors for thrombosis, such a person may be recommended to have thromboprophylaxis using low molecular weight heparin. But it's going to be done on a case-by-case basis. So the guidelines recommend prophylaxis rather than not to do prophylaxis. I hope that answers your question.
All right, thank you. Like I said, I know there are still a number of questions, and we can discuss until the cows come back.
Until later.
Yes, but Dr. Ddungu's email address has been shared on the chat. Feel free to ask him, and a question is offered to answer the question that you have for as long as they are sent to him. And you'll be sure to get them answered. I'm just going to invite Dr. Linda to give a closing remark in this discussion. And then I will also call on Dr. Ddungu to give a closing remark, and we shall end the session.
Okay, thank you very much, Jimmy. There was just one particular thing that we had skipped, and that's about our nursing care for these patients. So as you remember, I talked about us also incorporating in supportive care. So for most of us that work in very critical places, either the ED or ICUs, where we are having these patients more of being bed-bound. So our nursing care will come in to help prevent DVT. You've seen how a number of times we recommend these ICU patients having that 2-hourly turning. So for the nurses, we'd encourage you to continue doing that. Then for the patients that are able to talk to us, if they're able to express particular discomforts, yes, allaying their anxieties, talking to them, encouraging them to be ambulatory, elevating particular limbs that are painful, then also watching out for any other new signs or symptoms that might occur, and then you relay back to the managing specialties. So to conclude this, we want to thank you all for paying attention, for following. You've been completely engaged with all the presentations ongoing. So remember to have a high index of suspicion, proper management, and refer where you're not in a place that can give the appropriate management. Thank you very much.
Thank you so much, Dr. Linda. Dr. Ddungu, I welcome you to give your closing remarks.
Thank you very much. Ladies and gentlemen, I'll remind you and appreciate you for bringing on this topic. I don't know if you planned it or not. In a month where globally we commemorate thrombosis, October 13th is a day for the global awareness of thrombosis in whatever aspect it is. I am imagining that you planned for this because of this global awareness. Again, to remind people that 1 in 4 people will die of conditions associated with thrombosis. Hospital-acquired thrombosis contributes to 60%, and all these are preventable thrombosis. You talked about ambulating patients, but when you're in ICU, and I think we should stop fearing to order for the right things, because you guys are the managers of these units. You budget for them. keep in mind that any patient in ICU should have an automated pump on their limbs. You have seen that thing. Not just wear socks, but the pneumatic compression stockings that are automated. In the emergency medicine, start planning for such things. Start planning for treatment for these medicine, for these conditions. Not to just say in our situation. We are the people who make the situation and it has to change it. Don't expect Dr. Ddungu, who is an old man, to come and start changing things according to how things are now. So if we start planning for care for our patients in ICU, and in your budget, plan for such things that are going to prevent thrombosis. Thank you very much.
Thank you so much, Dr. Ddungu. You highlight very important points in management of these patients in the emergency state. And I'm very sure that EM is taking very right direction. And we are surely going to be getting these things in place so that our patients are adequately managed and promptly taken care of, so that we can avoid the complications that come along with some of these conditions. Thank you all for calling in. And I hope that the session has been beneficial, and I hope that it will help us to improve our care of the patients that we get in our emergency department, but also those that are on ward, like Dr. Ddungu highlighted, 60% actually are hospital acquired. That's when you're talking about pulmonary embolism. Thank you. I invite Thomas to give us the closing remark.
Thank you, Jimmy, and thank you everyone who has attended the session. We wanted to just highlight the polls and see how the performance has been, especially on the questions that people did not get in the right way. I have shared them with the right answers, so I'm asking Dr. Nalugya to briefly take us through some of these areas in the polls. Question 1, Dr. Nalugya, what was the answer and why? Sorry, I hope we are all able to see the questions. Question 1 was saying you are at risk for developing venous thrombosis or pulmonary embolism if you, number 1, you are obese or have had a recent surgery, you smoke, or any of the above.
Okay, thank you. So as we saw in our introduction, the different risk factors that are going to predispose us, being obese was there, having had a recent surgery, because we said this predisposes due to being immobile, plus also if it has been having the deep tissues, the deep vessels tampered with, then smoking. So the right answer here was any of the above.
Thank you, Dr. Nalugya. Question 2 was saying about 50% of patients with DVT also have which of the following? Do they have occult cancer, occult PE, protein C deficiency, or sickle cell?
So the right answer here was the occult PE. And by occult, we mean it won't be classically obvious, but we anticipate that they will eventually develop it, though they might not have that dramatic presentation to appear as if they have a massive PE. So the right answer here was the occult PE. This will be about 50% of the presentations.
Thank you. Question 3, it was one of the most, I think, controversial one. People got different answers, but it was saying during duration of anticoagulation treatment varies depending on the risk of DVT. Which of the following scenarios suggests the need to continue anticoagulation treatment for at least 6 months?
Okay, so remember we said that in the new guidelines, we are treating for a minimum of 3 months where we are able to identify the cause. So this means that you begin your DVT treatment as you also handle the cause that is causing it. So definitely by the end of 3 months, you're able to achieve your targets. And then for cases where you have either the massive iliofemoral involvement, or if you have malignancy, or where you have patients prone to being hypercoagulable and then getting recurrent DVTs, then here we're recommending gas giving prophylaxis going up to 6 months and beyond.
Thank you.
So the answer here being the idiopathic DVT.
Idiopathic DVT. So it's one of the answers that was selected by the list of people. The question 4 says signs and symptoms of DVT can include, I think a good number selected option 1, but you can still give a final take on that.
So still, remember we said that our DVT might be symptomatic or asymptomatic. For those that might have symptoms, what you're going to see will be the redness, the warmth, the tenderness, and the swelling. Remember here, the catch word was DVT, not because option 2 would be answering your PE. And then option 3 and the last one don't really qualify to be anywhere. So the right answer was option A.
Thank you, Dr. Linda, and to our participants, thank you for attending this session. We shall have our next session in a week, not in 2 weeks, and we shall talk about syncope. I believe we shall have a cardiologist with us to discuss syncope. So please turn up and also share with others to attend. It's on the 3rd of November. Shall be happy to have you, and this is going to be our last session under the phase approach to key syndromes. Those that have attended at least 8 sessions out of the mini sessions we've had under this phase will qualify for a certificate that's going to be awarded by Ministry of Health. We are trying to see the best way to award the certificate because this has been a long phase, and would love to really meet some of the people that have been able to attend some of these sessions. Other than that, I want to wish you a nice weekend, and we shall be happy to see you in a week. Bye-bye, everyone.